Hi, Vincent. Can you hear me? I'm CJ.
Hello.
Hello. Hi, Professor Fu.
Hi. Vincent,
Hey.
we cannot hear you.
Uh-huh.
Testing. Hello? Okay.
Hello. Yeah.
So you can hear me?
Hello, Vincent.
Yeah, it's great.
Okay, good.
Okay.
Okay.
Hello, Vincent. I'm CJ.
胡潮荣。
Good.
嗯
Can I share my PowerPoint?
Yes,
Yes.
please.
Let's see. Let me ask my technical people to come and help. Okay. 唔好意思，唔好意思，唔好意思，早咗叫你。我唔知呢個 how to share my PowerPoint。我嗰個
你係咪想 share 你？
係啊，呢度喺呢度，咁又唔知哦。
點解你入翻嗰個？點解會入翻呢個？
Vincent, do you want we share the slide from Taiwan side?
It's also fine. I see if I can manage to do the sharing here.
Mm-hmm.
Because we usually use Zoom. Apology about this.
Yeah, it's fine. Yeah.
應該可以 因為我哋已經 set 咗 rank 嘅，不過
係
呢度就唔解
open system preference.
因為
A bit strange. Don't know what happened. In that case, Zhong-Ling, maybe
Maybe
you
we
can share
we
my
share,
PowerPoint
yeah, okay. We share the PowerPoint
and someone help me to
to control the
change the
size.
slide. Yeah.
Yeah.
Thank you. Thank you.
我稍後時間講要求。
Okay. No problem. Thanks.
We will begin on time. It's 1 minute
Okay.
left.
Sure.
Okay, we'll begin today's dementia talk. I'm pleased to introduce Professor Vincent Mok, Mo Zhongtang. He's our old friend and a good friend. Professor Vincent Mok graduated from the University of Sydney in 1992. After 1 year of internship at Sydney, he returned Hong Kong in 1994 and has been working at the Prince of Wales Hospital since then. He was accredited specialist in neurology in 2000 and obtained his medical doctorate degree at the Chinese University of Hong Kong in 2006. He joined the Faculty of Medicine as associate professor in the same year. He was appointed as assistant dean of the faculty in 2014, the director of the Terry's Pefong Shaw Research Center for Prevention of Dementia, and the head of Division of Neurology, Department of Medicine and Therapeutics in 2016. To acknowledge his outstanding academic achievement, the university awarded him the Outstanding Fellow of the Faculty in 2016 and endowed him as the Mok Hing Yu Outstanding Fellow of the Faculty, a Professor of Medicine. He had served as the head of Division of Neurology from 2016 to 2022. He was appointed as the director of Margaret K.L. Zhang Research Center for Management of Parkinsonism in 2018. He was promoted to chair professor grade in 2018. He has so many appointments and outstanding findings. He's also appointed as a member of the expert committee on clinical events assessment following COVID-19 immunization by the Hong Kong government since 2021. In 2022, he was appointed as the master of S.H. Ho College, Chinese University of Hong Kong. In this year, he was appointed as the director of Lao Ted Chong Research Center of Brain Degenerative Disease in China. Professor Mok is an international rewarded researcher in the areas of dementia and the Parkinson's disease, especially in vascular dementia. He served as the chairman of VASCOG conference in 2018 and chairman of the local localization committee of co-chair of the scientific committee of International Congress of Parkinson and the Movement Disorder Society in the same year. Professor Mok received the Higher Educational Outstanding Scientific Research Output Award in Natural Science from the Minister of Education, People's Republic of China in 2011 for his research in cerebral vascular disease. Professor Mok is a very good teacher. He received 7 times Teacher of the Year award over the period in 2006 to 2012, and the Master Teacher Award of the Faculty of Medicine in 2012. Also, he is a very good speaker. He always teaches me something new. Today's talk has the potential to teach us a lot. Let's welcome Professor Mok.
Thank you very much, Professor Fu. A very kind introduction, and I'm really humbled. And I'm truly honored to be invited to give this lecture. And today, in the coming 30 to 40 minutes, I will share something new from our center. It's about machine learning method based on MRI for diagnosing and prognosticating Alzheimer's disease. Next.
厉害啊。
Okay.
Okay.
So this is my only relevant disclosure as a medical advisor of medical technology for brain analysis. Okay, next. So I will start with this case. A 60-year-old man that I saw with secondary educational level. He only has a background of hypertension. He presented to me with 3 months of increasing forgetfulness, short-term memory loss, but he was still able to work as a security guard. He did not complain of any heavy snoring suggestive of obstructive sleep apnea, which may also give rise to memory symptoms. And he denied any major depressive symptoms, which may also give rise to depressive symptoms. And his family history, his father had dementia not at a young age, but at the age of 80. And the physical examination was grossly normal and remarkable. No focal neurological deficit, no Parkinsonian signs, and no hemiparesis, all this. And the MOCA performed, he scored a 21, which just was about a 16th percentile. So that is, it's reached the threshold of mild cognitive impairment. So my impression is that he presented with this amnestic MCI syndrome. And as most of you are aware, there are many causes, and probably the commonest would be whether this patient is suffering from a prodromal Alzheimer's disease, that is Alzheimer's disease at the MCI stage. And if it is prodromal AD, then we are interested to know whether it will progress rapidly and convert to dementia in the coming years rapidly. And there are also other causes. Could be vascular MCI, especially small vessel disease, which is not uncommon in our locality. And there are all other much rarer causes that we usually need to rule out, such as normal pressure hydrocephalus. I had a few cases of brain tumor present with MCI in the past 2 decades, and also I diagnosed few cases of vitamin B12 deficiency and even hypothyroidism, a few cases of neurosyphilis each year for me, and sometimes we could not find any definite etiology for MCI. Okay, next. Next slide, please. Before I move on of how I work up, I would like to highlight that from recent studies, which I also participated, that among subjects with early prodromal or MCI Alzheimer's disease, that is with amyloid and tau inside the brain, but only with MCI cognitive severity. Actually, less than 50% will convert to dementia in the coming 5 years, less than 50%. And the most important predictor whether the prodromal AD will convert or not convert is whether the patient has neurodegeneration. I used the word N plus. So patient with A plus, T plus, and N plus, they are the subjects with the highest risk of conversion to dementia, whereas those with A plus, T plus, and N minus, there is no neurodegeneration, then the progression rate will be actually quite slow. Okay, next. Well, actually, to determine whether the MCR syndrome is prodromal AD and whether it will progress is very important, because in recent years we have emerging preventive treatment. I'm sure most of you heard of that. In the past 2 years, the USA FDA approved 2 monoclonal antibody anti-amyloid drugs, aducanumab and lecanemab, for use of early prodromal Alzheimer's disease. So it's very specific for AD and not for other MCI causes. And apart from this, we have a nutritional drug souvenir in Hong Kong, and also the structured multi-domain lifestyle therapy, including exercise, cognitive and social activities, aggressive control of cardiovascular risk factors, and Mediterranean of diet will slow down progression in the very early stage of MCR, or even in a very early AD. And there are also other issues such as personal planning for setting a will, advanced directives. All this are important if we diagnose the subjects have prodromal AD, and it will progress rapidly. So we have things that we can do now in this era. So making a precise diagnosis is important. And I won't go into details in this lecture of the treatment strategies. Next. So in this case, my first line investigations were that I performed a check bloods, and the vitamin B12, the folate, thyroid function, VDRL were all unremarkable. And as I also recruited him as a research case, so I also checked for plasma p-tau 181, neurofilament, and also the ApoE for genetic profile. And I also ordered an MRI for these subjects. The MRI did not show any normal pressure, hydrocephalus, or any brain tumor, but the MRI actually showed mild white matter hyperintensity around the ventricles, and also 2 lacunes. And at this stage, there is some evidence of a cerebral small vessel disease, but I'm still uncertain whether this mild SVD could induce the cognitive impairment. And for your information, it is quite common that normal cognitive elderly will harbor small vessel disease. It may or may not cause cognitive impairment. Okay, next. So for me, to confirm whether this elderly subject security guard has prodromal AD, the definitive test would be to perform either a cerebral spinal fluid analysis to check for A-beta or check for tau. As well, we can also do, in Hong Kong, we can do a amyloid and tau PET. But as you are all aware, doing a CSF is invasive, and doing an amyloid and tau PET. In the whole of Hong Kong, we have only 2 hospitals in private who can provide this PET imaging. So it is not easily accessible and very, very expensive, and not supported by our public hospital, not supported by our government. So this gentleman cannot afford pad, and he is not keen to receive a lumbar puncture. Next slide. So how can we further clarify whether the patient has underlying prodromal AD? So my next question is, can we actually, because he already had an MRI done, can we maximize the utility of MRI in assisting us to make a more accurate diagnosis and prognostication of prodromal AD? Okay, next slide. Now, over the past 20 years, actually, physicians, radiologists have been using, say, the medial temporal lobe atrophy or the hippocampal volume. The atrophy of this region is quite common and characteristic for Alzheimer's disease. So we have this official scale, a Shelton score, and in recent years, we can also quantify the exact volume of the hippocampus automatically and accurately. We call it volumetric and visual. So next slide. And a previous study also compared whether the overall accuracy and predictive value of volumetric versus visual. And they found that actually the volumetric had an area under curve of 0.71, and it was better than just relying on a visual scale with an AOC of 0.65 in predicting whether the patient having MCI would convert to Alzheimer's disease dementia in the next few years. So we could use a volumetric analysis of the hippocampal volume, aiding us, increasing our confidence in diagnosing prodromal AD. Next. But then there are also studies in the past that show that apart from the hippocampal region, there are other brain regions that could show atrophy in some degree, even in the preclinical very early stage. So apart from hippocampus, actually for early Alzheimer's disease, the atrophy may also involve the other parts of the temporal lobe. It could also affect the prefrontal lobes and also the parietal lobes. So a few years back, my research team asked whether we could use machine learning technology to identify this multiple brain region atrophy characteristic of AD, and we can use machine learning to increase our diagnostic and prognostic accuracy of very early AD. Next slide. And for machine learning, there are different technology, and the commonest probably is the support factor machines. And we can actually analyze the structural characteristic of MRI, which may include volume-based of different regions of the brain, voxel-based, and also cortical surface-based. Next slide. And in our team in Hong Kong, CHK, we developed machine learning based on structural. So first of all, in this machine learning pipeline, we developed automated brain segmentation and quantification method. And we published that actually our method, we use the name AccuBrain to determine, to name the software as we compare with another conventional free server software in quantifying brain regions. That AccuBrain, when compared with a manual segmentation, which is a gold standard, was more accurate than free server. That the AccuBrain quantification had a correlation with a gold standard volume of almost reaching 0.9. And it was much better than using free server with a correlation of only 0.75 second. Next slide. Next slide. Okay, and after this first step, our second step is that we develop a set of training data, which include 180 dementia patients due to AD, mild to moderate, with another 200 healthy control. So we had almost 280 dementia MRI and 200 of normal control, normal cognition MRI. So these are the training set, and based on this training set, using SVM method, and we develop a machine learning algorithm. And based on this algorithm, a tenfold cross-validation using this training data set, we found that the machine learning method had a very high AUC of 0.96. And this machine learning algorithm actually can generate an index. So each subject, when we go through this machine learning, then at the end, 10 minutes later, it will generate a number. And this index, this number varies from 0 to 1. And we call this index, we give this index the name of Alzheimer's disease resemblance atrophy index. In brief, AD rate. And this AD rate varies from 0 to 1. So if it is closer to 1, such as 0.8, 0.9, then it means the subject's MRI atrophy pattern and severity is very, very similar, almost identical to that of an AD subject. Whereas if the subject has a very low index of 0.1, 0.2, then it means it is closer, the MRI brain atrophy pattern is closer to that of a normal, healthy, elderly brain. Next. And we then partner with mainland neurologists working in Sun Yat-sen Hospital in Guangzhou, that they recruited 50 AD subjects with 50 normal controls. And these AD subjects were of moderate to severe dementia with MMSE of 14.7, quite severe, moderate severe dementia, and they tried to use this machine learning AD rate. Next slide. So in this separate, yes, this one. In this separate cohort, we found that AD rate was very accurate with an AUC of 92% and a sensitivity of almost 90% and specificity of 96% in making a diagnosis of Alzheimer's disease. And the AD rate actually performed better than when we just used single regions such as the hippocampus or the ventricular size or the whole temporal lobe in differentiating those with AD dementia and those with and those who were normal control. So we were very encouraged by this a small pilot study validating the accuracy of AD rate in a separate cohort. Next slide. And then we, so the previous study was very small, 50 AD subjects. So we increased the sample size, and the previous study was mainly we used the Chinese subjects. And now actually we expand the sample size, increased to more than 280 subjects and 1,000 subjects with cognitive unimpaired clinical status with 4 different databases, the ATNI, ABLE, OASIS, and also our Hong Kong Chinese CUCs. And we found that actually AD rate, and in this study, we only recruited those with mild dementia with a CDR of 1 and an MMSE of about 22, 23. So it was only mild dementia. So we found the AD rate with a cutoff in the index about 0.65 achieved a very good accuracy of almost 86% and 86 sensitivity and 86 specific. Overall, quite good, and it also outperformed the hippocampal volume or hippocampal fraction. Okay, next slide. And then in the same study, we explore whether this index will vary with age. And we found that we're relieved to find that actually AD rate was not affected by age. So we do not need to adjust for age when we use AD rate. This is different. If we use hippocampal volume, we need to, it depends on the age of the patient. If above 75, we need to slightly increase the cutoff threshold for the hippocampal volume. So it is quite complicated if the biomarker actually varies with age. But for AD rate, it will not be affected by age. So we can use it without age adjustment. Next slide. And then we explore. Now, the previous study explored whether AD rate could diagnose AD dementia. And now we would like to validate whether AD rate could predict conversion from MCI to AD dementia. So our first pilot study, again, was a small study based on ADNI. From ADNI, we identified 185 MCI, 50 was MCI stable, and 35 actually MCI subjects converted to dementia in 2 years. Okay, next slide. And this MCI had a quite high MMSE score, 26, 27. And we found that actually the AD rate had a quite good AUC of 0.771 in predicting the MCI converters. And the AD rate also outperformed the use of hippocampal volume. Next slide. So this, the previous study was a pilot study with a small sample size. And now we further performed a larger study. And large study, again, we recruited more subjects from ADNI. So we recruited 363 subjects with MCI syndrome. And then we retrieved the data from ADNI, include the MRI data, and we analyze all the AD MRI, and we generate the AD rate for all the subjects, hippocampal volume, and also the hippocampal fraction. And all the subjects had clinical data, age, gender, education, and MoCA. And also this subject also had the plasma p-tau and also plasma neurofilaments. So this subject's MCI around 71 years old, and the MoCA was around 21, 22, which was quite similar to that of MCI subjects in Hong Kong around age of 70 with a MoCA around 20s. And then we grouped this 363 subjects with 4 years follow-up into those who converted to dementia, we call the A+, T+, and C+, and those who did not convert to dementia as non-A+, T+, C+. And we found that actually the AD, A+, T+, C+ subjects had a very high AD rate of 0.9 versus those who did not convert had AD rate of around 0.6. Next slide. So we actually explore of different model the accuracy in predicting prodromal AD who will convert. And if we just use the clinical model, the AUC was 0.712. And if we use clinical model plus the plasma, it's increased to 0.788. And if we use a clinical model with AD rate, it was almost very close to that when we use plasma p-tau 0.779, and the AD rate outperformed other MRI markers. But overall, the best model was a clinical model which include age, gender, education, and MoCA, plus plasma p-tau, plus AD rate with a AUC of 0.828, a very sensitive 0.9, an overall balanced accuracy of 0.75, and the AD rate outperformed other photometric in predicting progressive prodromal AD. Next. Okay, so far we had confirmed the diagnostic and prognostic accuracy of AD rate. And then some may actually wonder how reliable is generating this AD rate. So we then conducted an inter-scan reproducibility reliability study, which means if we scan the same subject but using different MRI scanner, so will the machine learning algorithm generate similar index? So in this study, 11 subjects actually received scanning by 2 different machines. And we were relieved to find that actually the index, the absolute difference of the index generated by 2 machines upon the same subject, the difference was very small. And there was no significant difference in the index generated by these 2 machines. So AD rate, this machine learning, had good inter-scan reproducibility. Next slide. The second reliability measure of this biomarker is test-retest reproducibility. That means the same subject, but we scan at different time. In this study, we were very fortunate that we could partner with Professor Nick Fox in UCL along with engineers from Oxford. And then we were able to use the UCL very famous, we call the MIRI study, to test the test-retest reproducibility of AD rate. For your reference, the myriad, this minimal interval resonance imaging in Alzheimer's disease database, the objective of this study put up by UCL was to provide a mean to assess the reproducibility of techniques within a single day and over short intervals over 2 weeks, where there may be changes in individual saturation and scanner fluctuations, but not the pathological atrophy might be expected. Next slide. So in this study, testing the test-retest reproducibility of AD rate, we managed to recruit 69 subjects, and but 2 were excluded. And eventually, among the 67 subjects, we had 179 pairs of back-to-back scans. That is back-to-back within the same day. The patient will receive 2 MRI within the same day, back-to-back. And then we recruited 40 pairs of the scans that were acquired at 2-week intervals. That is, the patient had the scan at baseline, and then 2 weeks later at the same scan, and then we generate the AD rate index, and then we compare. So this is inter-time reproducibility, and whereas for the back-to-back scans in the same day, we call the within-day repeatability analysis. Next slide. And we found that we were also very encouraged to find that actually our machine learning generating AD rate had an excellent within-day back-to-back scans with an insignificant p, that is no significant difference, and then also a very good inter-time reproducibility with an insignificant p, and an intra-class correlation reaching 0.9 for the within scan and the inter-scan reproducibility. Next slide. And we were very happy that we managed to publish this reliability study of AD rate recently in the Frontiers in Aging Neuroscience. Next slide. So because of all these very encouraging clinical validity and reliability results, of using AD ray in predicting and prognosticating early AD, we integrate this machine learning method into a real-life clinical practice. So nowadays in Hong Kong, we could easily, the radiographer could upload the soft images to a cloud server, which is very secure. And then the server can generate the report with the AD ray, the index, back to the radiographer and radiologist in 10 minutes. And it's commercially available now for use and commonly used in Hong Kong in assisting the diagnosis and prognostication of AD in Hong Kong. Next. Let's come back to this case, security guard, and eventually we submit the MRI images to the AD cloud, and then the AD ray generated back was only 0.11, which means it's a low AD ray. That means the likelihood of having prodromal AD was low. Next slide. And then we, as a research case, we performed the amyloid and tau PET for this subject. And eventually, we found that this patient did not harbor amyloid nor tau burden in his brain. Next slide. So this is a vascular MCI case rather than a prodromal case. Next slide. So in summary, this AD ray is a machine learning derived MRI-based biomarker for Alzheimer's disease that is commercially available now. And it can guide selective PET or CSF investigations for confirming A plus T plus N plus and C plus for MCI subjects. And it is valid in diagnosing AD dementia and predicting conversion of prodromal AD. And it's achieved excellent interscans and test-retest reliability. And it is applicable, it could integrate into a busy day-to-day clinical setting. And potentially, it can enhance a cost-effective management of MCI. However, there was a limitation. The AD ray will also be high in subjects with frontotemporal lobar degeneration, in dementia with Lewy bodies, in subjects with very severe diffuse small vessel disease. So AD ray, a high AD ray was not specific for Alzheimer's disease. So we need to apply AD ray in subjects who are clinically compatible with a diagnosis of Alzheimer's disease. And in case you encounter a cognitive impaired case with prominent behavior problems, like a FTLD or with Parkinsonism, or if the MRI shows very diffuse small vessel disease, then the AD ray is not accurate or valid in detecting prodromal AD. Next slide. So I would like to thank my clinical colleagues and engineer and radiologists and other institutions in helping us in developing biomarkers for early Alzheimer's disease. So thank you very much for your attention, and I wish all of you a good brain health. Thank you.
Thank you, Vincent, for the nice talk. Any question from the audience?
Hello, Vincent. I'm CJ.
Hello, CJ.
Hello. Yeah. Regarding the case you present, I wondering the vascular pathology is so minimal.
Yes.
So I'm not sure we should classify as the vascular MCI?
Yeah, thanks, CJ. This is a very good question. I cannot say. I think the definitive would be to perform a brain biopsy later. But you're right, it's so minimal, just grade 1 double MH and 2 lacunes. But actually, one of the lacunes actually was located in the thalamus. So a thalamic lacune actually has a higher propensity of inducing cognitive impairment. So, and then I excluded other causes, even tau PET and amyloid PET, and other blood tests for B12. I could not find any other causes. So eventually I labeled this gentleman as a vascular, but I fully agree with you, CJ, that I cannot be 100% sure that this is really the cognitive impairment is accounted by this very mild small vessel disease. I cannot be 100% sure. Thanks.
Thank you.
Any other question?
Yeah, I have another question. Because the machine learning is very powerful, it's possible to do the differential diagnosis like AD from FTD or DLB.
Yeah, so your question is, can machine learning differentiate DLB, FTD, and with AD, am I right?
Yeah.
Yeah, I do not have time, but if in the future, I can actually talk about my other studies, which we also develop a FTLD machine learning algorithm and also a DLB machine learning algorithm. But the overall results are not as good as the AD rate. But we develop other machine learning algorithms, differentiating AD with FTLD and AD with DLB, DLB with normal control. We have studies on this area too. Thanks for raising this issue.
That's the question from Chao Rong. And I think purely on MRI machine learning, it is really difficult to differentiate the AD from DLB, maybe FTD also. But I'm pretty surprised that the VCI with extensive white matter lesions, it is also not. Is it possible to differentiate from AD from MRI?
Very, very difficult. Actually, we found that for very severe small vessel disease, the brain also shrink with brain atrophy. And many times the brain atrophy pattern associated with severe small vessel disease mimic that of Alzheimer's disease. So for severe small vessel disease, the many subjects was in our stroke cohort, the severe small vessel disease also had a very high AD rate. But when we perform an amyloid PET, the amyloid PET was negative, but sometimes was positive. So for severe small vessel disease, it's really hard because it's also associated with brain atrophy.
Okay.
It's not easy. Yeah.
Maybe we need to add such as p-tau information in the model.
Yeah, good point. Very good, Jong-Ling. We can explore this in research. Excellent. Excellent idea. Thank you.
Dr. Lin Yongxuan, she raised a question. How is the influence of normal aging accounted in your machine learning model?
Yeah, this is so somehow as our computer engineer designed this machine learning, Professor Shi Li, incorporate adjusted the aging effect related brain atrophy in the model. So somehow the AD rate in a normal elderly 70 years old versus a normal elderly at 90-year-old, it was similar. It would not increase the AD rate. The reason was because we already adjusted for age-related brain atrophy. So
And
we do not.
How about the gender?
Gender was not affected as well.
Uh-huh.
We did not adjust for gender, but there was some slight gender difference. Very good. But it did not affect the overall diagnosis and the accuracy of diagnosing and predicting AD rate. We performed subgroup analysis. Thanks for asking this.
Okay.
Excellent question.
One question from Dr. Huang Likai. How AD rate deal with asymmetry atrophy, or to hint of mixed pathology?
How did AD rate
Deal with asymmetry atrophy?
deal with what atrophy?
Asymmetric.
Asymmetric atrophy.
Mm-hmm.
Asymmetric atrophy.
Yeah, I guess the question is that most of the AD patients, the brain atrophy show the symmetric, but the other etiology may be asymmetric, like frontotemporal dementia. Do your machine learning to include the symmetric as a parameter for the machine learning?
Not really. Not really.
Thank you.
Yeah.
And how AD rate deal with the mixed pathology dementia?
Now this is a very difficult question. So it is very difficult as you recently asked about the SVD. Many in our stroke cohort, many small vessel disease also harbor amyloid plaques. So AD rate could not actually differentiate whether this is a mix or pure SVD. So this is very difficult. So this is also a limitation of AD rate. So if I encounter a subject, the MRI already show quite severe small vessel disease, then it's not applicable.
Okay. Dr. Li Weiru, you can ask by yourself.
Okay, I'm Dr. Li. Thank you, Dr. Vincent Mok. And so my question is similar to the last one. And do you consider the cerebral vascular pathology in the AD rate? I think the answer is no, right?
No, unfortunately.
Okay, thank you.
Yeah, very good question. Actually, these are the questions that the reviewer had asked me about. Yeah, its application in subject with SVD can the differentiate mix. What about FTLD and DLB? So these are most commonly asked questions. So it's not, yeah, cannot.
Yeah.
Thanks for your question.
Thank you.
Thank you.
Any other question?
Okay, I have another question. And Dr. Vincent, do you think that the AD rate can replace maybe amyloid PET to predict the conversion of MCI subjects?
Yeah, I think AD rate can say if the subject has PET or CSF confirming amyloid positive. That means the patient has either AD or Alzheimer's continuum.
Yeah.
Then the AD rate can actually help to prognosticate how quick this AD or Alzheimer's continuum subject will progress in the coming years. So I think AD rate is a very good neurodegeneration surrogate. Yeah, it's slightly less sensitive than FDG PET, but it's much better than if we just use visual or photometric analysis.
Yeah, thank you.
Thanks for your question.
We still have time. Is any other question? Okay. Dr. Huang Likai, you can answer yourself too.
Oh, yes. Thank you for your wonderful talk. My question is the repeat MRI measurement using AD rate better than one measurement if we have like 2 or more years of follow-up. Thank you.
Now, AD rate, I did not share, but we were analyzing longitudinal data, AD rate in year 1, year 2, year 3. And then we also had in the ADNI, they had year 1, year 2, year 3 pathology and cognitive data. And we found that actually a serial AD rate correlates with serial change in pathology, and also correlates with the change in cognitive status as well. So in my clinical practice, we had AD rate, we had encountered subject with a subjective cognitive decline, and the AD rate was 0.3, which was less than 0.5, 0.3. I observed, but then 1 year later, the AD rate increased to 0.6. So this is, wow, increased by 0.3 points rapidly in 1 year. And this is fair, and this suggests a rapidly progressive case. So then I performed an amyloid PET in this subject and confirmed amyloid positive case. So it seems the change to measurements also indicate a more rapid angry pathology. So it has the potential to be used as a longitudinal monitoring of the disease progression as well.
Thank you.
Thanks for your question.
Yeah, I have another question. Sorry. Yeah, and Dr. Mo, do you think that the brain CT can be used like this way as a brain MRI? Because there are some doctors try to use CT to predict the prognosis of dementia when they have patients in Taiwan. Yes.
Yeah, I know. Actually, I think in principle, this is really feasible. That if we have a large sample, a training data set, we can also use similar machine learning to explore the utility of a CT. And this is potentially feasible. So probably less expensive. Yeah, so very good research direction, especially for region that is, or people that could not afford MRI. We can really explore this research direction. But of course, CT has its own limitation. Although it's less expensive, cannot pick up small vessel disease. Yeah.
Yeah.
I agree that the CT scan is a good idea. Maybe the sensitivity and the specificity lower than AD rate, but it can provide information for something.
Agree.
Any other question? If there's no more question, then we thank Professor Mok for his excellent talk, and we hope that Vincent can come to Taiwan in person.
Yeah, I will. I'd love to. Okay.
Yeah.
Thank you very much. Yeah. Really enjoyed the
Yeah.
discussion. Thank you.
Okay. Yeah.
Thank you.
Catch up later. See you soon. Bye bye.
Yeah. Okay.
Bye-bye.
Bye bye.
Bye bye.
Mhm.